I'm going to follow up with you and then open it up a little bit, because you were the one who mentioned earlier about patients getting a long journey and misdiagnosed along the way, maybe more than once. What can we do systemically or on the clinic or with payers to try to identify those patients earlier? And what are some of the things that your institution may have tried?
Yeah, so we're particularly interested in this at UC Davis. We've developed a screening program here where we screen all CTs that are performed at the institution for keywords. We've got a nice software program that will pick out just the mention of articulations or traction bronchiectasis, that sort of thing. And will send me a monthly report of all of them. And we go through and figure out which ones have a pulmonologist and which ones don't, and make sure we follow them up. We also screen all the pulmonary function tests done at our institution. We have a algorithm that applies this equation to every PFT, and we've developed a pretty good classifier for identifying ILD with about 80% sensitivity specificity, and we do this in the primary care setting. And so whenever a positive screen comes back, again, I get a weekly list, and we follow up with the primary care doc to make sure they're getting in for a high-res CT. This is sort of focusing on high-risk populations, right? If you're undergoing a CT or a PFT, it's probably because you're a bit higher risk of having a lung disease. What we can do in the general population, I don't really know, because it's a pretty rare disease, and so systemic screening is probably not cost effective. But if we do focus on these high-risk groups, I think it will yield results, especially in the rheumatologic world. If you have a patient with scleroderma, I think most of us agree now that every patient with scleroderma at diagnosis should be screened for ILD. I think the same is probably true for myositis and rheumatoid arthritis as well. Other rheumatologic diseases are a little bit less common or a little bit lower prevalence for ILD, but if we do focus on these high-risk groups, I think it'll pay dividends for us.
Dr. Danoff, do you have anything to add to that in terms of earlier detection?
No, I think that we have to contextualize the delay that sometimes happens for patients who are diagnosed with interstitial lung disease. I mean, interstitial lung disease really is an incredibly rare disease in comparison to many of the more common disorders like COPD and asthma. And, for a woman like Dawn, who was healthy and active and then noticed she was short of breath, I mean, thinking that it might be pneumonia is actually probably a pretty reasonable choice. If we always jump to the rarest diagnosis, we'd be more often wrong than we would be right. So some of this delay that we appreciate is because these are very rare diseases. And I think that the issue is not so much that it isn't reasonable to consider another diagnosis first. It's that interstitial lung disease needs to be on people's top 10 list of what, somebody who shows up who has what might be a pneumonia, but it doesn't resolve, or who has, rheumatoid arthritis and finds that they're short of breath, or who has, gets a drug and starts to cough. I mean, it just needs to be something that has, particularly amongst primary care providers, it needs to be high enough on the list of differential that people actually really think of it before a lot of time goes by. And I think that, all of us agree that, it shouldn't be necessarily the first thing on your list, but it should be on your list.
And how is the current situation around COVID and access affecting this population or your ability to see patients?
So I can say for us, right now, I'm not in the clinic at all. So all the medicine we're doing now, with rare exceptions, is 100% telemedicine. And, I can certainly assess for somebody's symptoms if things are getting worse, but right now we're pretty limited. We don't have the ability to get some of our screening tests done, like pulmonary function tests, and patients are frankly afraid to go into the hospital to get tests done or to see their physicians because they're immunosuppressed, or they have, and they have lung disease. So we're a little limited in our ability to get some of this ancillary data that we usually rely on to help assess when our patients are getting worse.
And I think we were just discussing this at the very start. The thing I've been most impressed with is how few of my patients have actually been affected with COVID-19. And I credit that with the fact that our ILD patients are very well educated. that when it comes to viral seasons, they need to be exceptionally careful. So our patients were self-isolating before that word came up. And, they've done an amazing job of just doing what was necessary to stay out of harm's way.